everyone, and welcome to Take a Pause with Menopause, where we will talk about the pause in all of her glory and not so glory. But the conversations will be real, honest, and funny because Lord knows we have to laugh during this time. I mean, there's a lot going on. And today's topic is another conversation that always seems to be a little silence around it. It's the GSM and your pelvic floor. Now, we have an expert here that will say GSM because in my Jersey tone, I will just mess it all up. So I'm glad to have Debbie here, my other partner in menopause. Hello, Debbie.
Hello, happy to be here. I'm excited to learn.
And we have Gisele, our favorite nurse practitioner, who is going to make sense of how when you want to sneeze, it's sometimes a good decision and sometimes a bad decision. And girls, we all know what we're talking about when I say that. So we say welcome to Gisele. How are you?
Good. I missed your faces, so I'm glad to be back.
Same. We missed you.
Thank you.
Yes. So this is, we figured, it's a hot topic that nobody really talks about also. So it's, I know we talked about the tea with you, and we learned so much. How about it, Debbie? Like 2 episodes. So we're like, if we can bring knowledge and awareness to the tea, think about what we could do for this.
Yes, ma'am.
Which,
or for the V,
I was ready to say that. But, this is such a, I don't know, what would you say, like a taboo, or I don't know, what's the word, like where nobody really wants to talk about it. And growing up, nobody really talked about it. And I'm still learning how to talk about the V, but I always tell people, hey, what's going on down there? And I feel like growing up, nobody talked about it. Like my parents didn't say, hey, what's happening down there when I go to a doctor. It was so silent. And it's caused a lot of us to have a lot of issues, because if we would have known what was happening down there and been observant of what was happening down there, we wouldn't be where we are right now.
Or even just how to describe what's happening. Like it's, everybody laughs when, you sneeze and you're like, oh, everybody knows. Like you lock eyes with another woman, like they'll watch you sneeze and you're like, ooh, okay, we're good.
Yes, but I want you with Gisele to actually say what GSM stands for, because I know I can't pronounce it either.
No, I'm not going.
And what does it mean too?
Right. So the term changed in 2014. It used to be vulval vaginal atrophy, which isn't that wonderful?
I've heard that.
Yeah. So, we still to this day say vaginal atrophy, and it's like, oh, that's great. My vagina is atrophying, what does that mean? Right. And, there's a lot that's still taboo. Just hormone therapy in general. Over the past few years, we've really made strides on talking about hormone replacement therapy, talking about sexual health, testosterone, just everything women's health, right? So GSM stands for genitourinary syndrome and menopause. And so it's really kind of like that umbrella term that we use for so many things that can be changing down there. And so what it really means is that there's a decline in estrogen that's affecting the health of the vagina and the vaginal tissue and urinary tissue. We're talking about thinning of the tissue. I talk to patients all the time and they're like, I don't know what's happening, but man, having sex, I feel like I have little tears, or when I wipe, it hurts. So, the tissue is thinning. There's decrease in elasticity. Natural lubrication seems to be just
non-existent.
Non-existent, right? It's literally when women say, I feel like the Sahara Desert down there. Well, yeah, because we have no estrogen. And it really, when we have that lack of estrogen, The vagina, the vaginal tissue in the vagina really has its own little ecosystem if you think about it, right? And so when we have those shifts, it changes the vaginal microbiome and the pH. And so when that happens, we're more susceptible to burning, irritation, pain with intimacy, recurrent UTIs, urinary frequency that we never had, or urgency. So that shift really does change everything. And it's just not, it's not just the vaginal issues that we're dealing with, because it's the quality of life and the issues how it impacts us too. How many times do you hear a woman say, okay, where's the closest bathroom? Or I got to go on a trip. I have to, you know what I mean? So it's like, we're mapping things out. Or like Deb's, like Mare said, sorry. Okay, we sneeze or we cough, and it's like,
oh, it is. Like, you feel it coming on.
Yeah. Yeah. And so, it impacts everything. It impacts our confidence, especially, okay, how many times have you guys been in a group of people or presenting and you're like, oh God, please don't do this. I can't cough or sneeze right now because I can't cross my legs, because if I cross my legs, I'm trying to hold in the pee, so
and then everybody will know. That's a telltale sign. Like, you see it, you're like, oh yeah, no, I'm not crossing my legs to, be demure.
Yeah.
No.
I know. I'm not doing that. And so, it affects everything, sleep and well-being. The biggest take home is, I want women to know that this is common. This does happen. There's so many things that impact GSM and the pelvic floor. Like, when we talk about GSM, we can't just talk about genital urinary syndrome and menopause, the changes that happen. We also have to talk about the pelvic floor and the health of the pelvic floor.
Yeah.
So when, I'm going to totally just probably embarrass my daughter. Well, you guys don't know my daughter, but anyways, when she was little, I'm going to embarrass myself. When she was little, she sneezed a couple times, and like, she crossed her legs, and I was all, for a little girl to do that. So I'm like, I like brought her aside and I said, is everything okay? What's going on? Does it burn when you go potty? Like, what's happening? And she goes, what are you talking about, Mom? And I'm like, baby, you're like crossing your legs when you sneeze. I said, what's going on? And she goes, nothing. And I said, then why are you doing that? And she goes, because I see you do it. So I see you have to do it. And I'm like, oh
my gosh.
Yes, I got to go see the pelvic floor therapist because,
oh my gosh.
Yeah. And so,
it's just such a sweet, funny, and
I think it's very sweet.
Moment, all in one.
All
like
in
I
one.
See you doing. It's like,
that's so cute.
Yeah. So we have to talk about the pelvic floor and all its glory too, because that's part of everything. And I have my model with me. This isn't my favorite model because I can't tear it apart.
We love models.
I really need a model because I don't ever look down there. So it helps me.
I am going to tell you the number one thing that I tell my patients all the time. You need to know what your tissue looks like. You need to know. Listen, if you don't want to do it, invite your husband or your partner to do it and say, what does it look like? Because it's really important. As women, we are never taught, when we're talking about the anatomy of the vagina, right? This is, again, not my favorite model, you guys. You can't really see. I'm not going to use this model. We have the introitus, which is the vaginal opening. We have the inner lips and then the outer lips. Well, in between the inner lips up to the clitoral hood or up to the clitoris is the vestibule, right? The clitoris, which has 10,000 nerves.
That's amazing.
Yeah.
Right? It is. It has the clitoral hood, which is synonymous with foreskin, right? As women, we are never taught that we need to pull that back and clean, right?
Oh, yeah.
Just like with a little boy, for those of us who have had boys in the past before, if they've ever been circumcised or whatnot, we were always taught, you got to push it back, you got to clean it, let it dry, and then put it back. As women, we need to know what our tissue looks like. I know, right? You're all...
I didn't even know that existed. I had no idea.
Yes.
Like,
It
seriously.
it totally exists. And so when I talk to women and they're like, I can't orgasm or I can't do this, I'm like, listen, that little clitoris has 10,000 nerves. Something's going on. We need to figure out what's going on. Is it
Well, that is true.
hormonal?
Yeah.
Right. Is it hormonal? Do we have adhesions that are blocking that? Is there discharge? Is there keratin pearls? What is going on?
What's that?
So a keratin pearl is basically
It sounds pretty, but I don't really think it. I
No.
don't think it is.
Did you know what it was? I didn't know
No.
what it is. Okay,
No,
good.
I do not.
I had to ask.
anytime we hear the word pearl, we're like, ooh,
I
that
know.
sounds so
It's like
nice, yeah.
Right. Like
But
earrings.
it's
It's not.
I don't
Apparently.
know. With some of the stuff that maybe you can turn it into earrings. I suggest not.
Oh,
but
no.
yeah, so it's just a bunch of like discharge and keratinized junk that gets stuck underneath the clitoral hood that kind of causes an adhesion, and so that can cause
Get that.
yeah, that can cause issues with orgasm.
Right. Because it would
sometimes-
decrease the sensation.
Absolutely. Yeah, and it can cause discomfort. There's just a lot of different things that can come up with this, right? So when we talk about genitourinary syndrome and menopause, we really need to talk about the pelvic floor as well, and all of the things that can impact this. But truly, when we talk about GSM, we are also discussing the vestibule, which is we're talking about the introitus, which is the vaginal opening, the vestibule, which is in between the inner lips up to the clitoral hood, the vagina. We're talking about all that because that tissue has estrogen and testosterone receptor sites. It's very rich with estrogen and testosterone receptor sites. And so when our estrogen decreases, testosterone decreases, then we start to have a lot of those symptoms. In the urethra itself, right? Women may say, man, I just have this sensation of urgency, or I have to pee. Well, there's issues that can happen with that, right? So it's very much a topic that we need to talk about. It needs to, as providers really need to hone in on recurrent UTIs. A lot of women who come in and they're like, oh, I got a UTI again. I don't truly think it's a UTI. It's the inflammation that is happening.
Oh, I see. Yeah.
You see what I'm saying? So it's the inflammation that's happening that's causing that sensation, right? And so we as providers are overprescribing on antibiotics. Well, now what does that do? It's the whole down like slippery slope, right? So we really need to get better. Hey, let's get some vaginal estrogen cream. Let's get some good stuff on board.
Mm-hmm. I didn't even know that there was testosterone receptors down there.
Oh yeah.
I didn't either.
Yeah.
That's another thing. Like I just thought it was like all just estrogen because they talk about like just putting like the estrogen cream, you know, that would help down in the vaginal area. But I know that's very interesting.
It is, and so you know when speaking to patients about optional treatments, everybody goes for estrogen, which is fine. And a lot of times estrogen works. What type of estrogen delivery system? We have an estrogen cream, we have an estrogen tablet, we have the little Imvexi suppositories. Truly, my favorite is Intrarosa. And Intrarosa.
You showed us that.
What?
It's a syringe.
It's a suppository.
But is it in a tube?
So it's this little guy. It comes with an applicator.
Yeah.
Yep.
That's it.
So,
Yeah.
Yep. So Intrarosa is DHEA, and so it's not estrogen. It's not testosterone. It's DHEA, it's progesterone. And this medication is truly the only medication that at the cellular level changes to what your body needs. Remember those
Whoa.
estrogen and testosterone receptor sites I told you about?
Yep.
This will occupy both of those. And it is originally, this was made for painful intercourse. And it really is not, so it's not a true hormone like estrogen or testosterone, right?
Right.
It's DHEA, which is a precursor. So when it changes to what our body needs, those estrogen and testosterone receptor sites are occupied, and it's magical. It truly is. And
That's amazing.
I have been prescribing this for probably 13 years. A lot. I've been using, from when it first came out, I have been prescribing it. And I can probably tell you that on one full hand, I had to have probably 5 patients who have said, I don't like it. All the other patients have liked it. Their husbands have come in and said, I love you, thank you.
Yeah.
And it truly makes a difference. I've had patients who have said that about estrogen, right?
Right.
Now, depending, we can also compound a special cream to put on the vestibule if we're having, issues with pain or discomfort with estrogen and testosterone. So
that would be super cool. I just know that putting that, I mean, is it messy? Is it like, does it
No,
absorb easy? No, I mean the tablet thing that you just talked about, the DHEA.
So
An
this
introvert.
one, I love that you brought that up, because this is something that we talk to patients about all the time. Well, I talk to patients about all the time. So with the vaginal estrogen cream, it truly is the suppository. You put
Right.
the tube,
Right.
you fill this up, right?
Yeah.
What goes up must come down.
Right. Yeah.
So, and with the cream, that's one of the biggest things that patients are like, I don't like it. It's messy. It's gross. It just feels ugh. So a lot of times when patients use the cream, I tell the patients, and I invite them, I'm like, look, insert it. You have to put your finger in the vagina, rub it into the walls. Put it in the vestibule, right? So that's how you can get the effectiveness of one way, right? To really get it to absorb in. The DHEA actually is amazing. It's one of my favorites. I have no obligation to the pharmacy or to the manufacturer who makes it, but I love it because it's made of a derivative of coconut oil.
Ooh.
So it's very soothing for the skin or for the tissue.
Yeah.
It's silky. Yes, sometimes when you put it in, you'll have a little bit of residue on your panty or on a panty liner, but nothing compared to what vaginal estrogen is.
Yeah.
Right. Especially if you don't rub in the cream, right? If you put it in, sometimes it's like it just clumps up.
Yeah.
One thing that I love to tell patients to do with this is with the DHEA, the Intrarosa, typically is every night. You use it every night. I tell patients you can break it in half, put half inside the vagina, take the other half, and just rub it on the vestibule, because those receptor sites are really gonna just take them in. Last year, 2025, I believe, the American Urology Association said that used Intrarosa as a form, or accepted Intrarosa as a form of treatment for GSM, which is great, because originally it was just for dyspareunia, which is painful intercourse. That was the indication for it. But now we know, because the Urology Association has said, nope, we can use it for GSM as well. Still, it's kind of a little bit hard to get it covered by insurance, but not too bad.
I was
Of
waiting.
course.
I was.
You're
gonna
waiting for
ask-
that.
I was gonna
Yeah.
ask, what's the catch? This is too good. The people
Yeah.
are saying it's good. It's really great.
Yeah.
What is stopping women from getting it who need it?
It's
the
insurance. It's insurance. Always, I hate to say this, and I'm not, sometimes we're very limited by insurance, or we have to jump through all these hoops to do prior authorizations.
We
and it's
totally
like,
know that.
Yeah, you guys, we get that, right? And then there's other methods like Uvafem or Vagifem, which is a tablet of estrogen, right? So it comes with a suppository. You use it every night it's similar to the cream on how you use it. So if you're getting started on it, it's typically a loading dose. So every night for the first 2 weeks and then twice weekly thereafter. So that goes the same for the vaginal estrogen cream, the Uvafem, or even Imvexi, which Imvexi is the capsule that you use vaginally as well. So I would probably say the messiest is the cream.
Yeah. But it's, I mean, girls, we've all used Monistat, right?
Oh,
Exactly.
Like,
I grew up on that. It's like every month I had it. It was like no fair.
It seems like the same concept. Like, yes, it's we all know it. You put the tube in there, but it's like you need it. It works.
Right.
So you sort of like put that like, okay, I know this may be messy, but it is something that we all need. So
Absolutely.
It's like,
Can you use both? Oh, sorry.
Go ahead.
No, can you use both the DHEA and the estradiol?
You absolutely can if you do like the estrogen cream for the outside vestibule. You can, and then you can use the
for the inside.
Rosa for the inside for the vagina. And one thing that I tell patients all the time, what I like about the vaginal estrogen cream, which is really important, as we get older, the urethra, where the urine comes out of, can prolapse essentially, right? So you can have what's called a carduncle, excuse me.
Yes.
And so that tissue is susceptible to bacteria, right? It can get inflamed. It can just be uncomfortable. So I tell patients all the time, I'm like, you get that estrogen cream, you put it on your finger and you rub that urethra really good, and you get that in there to help prevent any types of UTI or because that's a lot of times that's what we're feeling, right? We're feeling that discomfort.
Right. And you think it's a UTI because you remember, oh, this is what it feels like, but it's just really from the irritation and from the exposure and dryness.
Yeah. So we want to be careful with that, right? So, and that helps. That definitely does help with prevention too, right? Women are more susceptible to UTIs and to sepsis as they get older, and a lot of times that can be prevented.
I know, like, what is the correlation? Because I've heard people say, if women, when they break a hip, then you get the UTI and then you die. I was like,
it's pretty scary.
Where the hell where did you go from being like upright and normal, you break a hip, UTI, like, but is it just because of the estrogen and everything is just all, like,
it's a combination of things, right? So one common, and I, of course, Mary, you know how we go down rabbit holes and everything.
Oh yeah, I love it.
I know, right? It's just one thing after another. So especially in elderly patients, they may not that they can't communicate it or say it, right? But we may not know.
Right.
But a lot of times what can be a tip off for our loved ones who may be taking care of an elderly parent or, somebody who's advanced in age is they change. Like all of this, sometimes it's a drastic change. Sometimes it can be a subtle change, right? I always tell patients or their caretakers, listen, go get a urine culture.
Yeah.
Let's see what's going on. Because if they're having this change in cognition or mental status, do we have an underlying infection that's going on?
Yeah.
That needs to be treated, right? And for women who are getting older in age, there is nothing wrong with using vaginal estrogen cream or, Intra-Rosa or even Uvafem, right? A localized estrogen is going to help that tissue stay healthy and prevent a lot of the bad things that can happen with with the decline in estrogen.
I know, and I think that too, it's like, because there is still, even though, like, we all know the black label came off, but I still think there's still such a stigma that nobody wants to give the estrogen, yet alone tell you, oh, use the cream on your vaginal area, use the patch, it's very hard to, it's sort of like one or the other, is what I've heard, like, talking with other friends that are like, oh, I can't do both. And I'm like, yeah, you can.
Absolutely you can.
Yeah.
Absolutely you can. And I have
they're
a lot
not getting it. Yeah.
They're not. I have a lot of patients who, or, you know, vice versa, right? So I've had a lot of patients who have told me, my provider's not going to put me on systemic estrogen. I'm just getting vaginal estrogen.
Yeah.
And it's doing nothing for my hot flashes. Well, of course they're doing
Right.
nothing for hot flashes because that's systemic. Kudos for being on or localized estrogen.
Yeah.
Kudos for her putting you on that. But now we got to do something about this, right? About the systemic symptoms that you have.
Yeah.
But localized estrogen, right? I mean, you can absolutely be on systemic therapy and localized and be covered and be okay. It's not a lot of estrogen.
Right.
You know, it's a lot of providers and even patients, right, are like, well, my symptoms aren't that bad. I'm talking about systemic therapy now.
Yeah.
They're not that bad, so I may not need that. HRT is not just about symptoms, right? Like, nobody wants
Correct.
to walk around feeling like
Correct.
shit, right? Like,
Correct.
right? But we need to also talk about the health benefits of it. We need to talk about cardiovascular prevention,
Yeah.
bone health, brain health, right? I have had a lot of patients who are like, listen, I got started on systemic therapy and all my GSM symptoms went away. That's great. That doesn't happen for most people, right? Sometimes it does, sometimes it doesn't. So for them, I have the conversation, okay, if you start feeling like we're having recurrent infections or you're feeling kind of just different, then at that point we can start a vaginal treatment, right? The earlier we address it, the better outcomes we have,
Yeah.
right? If we're waiting, then that means that we've gone over some time and now we're starting to have those symptoms.
Right.
So let's address it. Let's get this stuff done, right? Yeah.
So what can, because I know there's, and I learned from you that there's more than just Kegels to help with your floor. Like, but I had no idea before talking with you about it. I think it was Debbie, we were on here and I was like, well, they say Kegels. And you're like, yeah, that's good.
Yeah.
But
You're absolutely correct, right? So there's a group of muscles that help
well, the
support.
model's coming out again, Deb.
Here comes the model, I know.
The model's coming out, but it's not the good model, so I can't really differentiate. This is your pelvic floor from the inside. This is the pelvic floor from the outside, right?
Okay.
So we have a group of muscles that it's like a hammock, right?
Okay.
Now, when we do Kegels, so these muscles, just like any other muscles, they need to be exercised, right?
Right.
Because that's going to help support the organs that are in that area. Uterus, bladder, rectum, all of that. So yes, those need to be exercised. But when everybody says Kegels, if we're not doing them right, we can kind of overshoot, right? So we can actually cause a symptom called hyperpelvic floor dysfunction, where we've engaged muscles up here, but have done absolutely nothing for these muscles, right? For the bottom muscles. And so,
Interesting. If you look at it like a hammock, so your
Exactly.
it's too tight up here and still just flopping.
too loose,
on the bottom.
yeah.
Hmm.
So,
Love the hammock.
love the hammock. We got to have a hammock, right? So, during perimenopause and menopause, those hormonal changes can affect, the muscles. Childbirth, number one cause, right? Can affect the muscles. Chronic stress. There's a lot of different things that affect the pelvic floor. And so, it's not just weakness that may have that's going on with those muscles. I always tell patients, and I think we've had this discussion on another podcast, you should always phone a friend, remember?
Yes.
So
Yes.
you should always have a sexual therapist, a pelvic floor therapist, and a colleague, a good colleague that you can run things by. But, you know, being overactive or tight muscles can cause issues, right? So it's really impressive when you go in, and I've counseled patients on this. I've done exams, and I'm going in and I'm feeling their muscles, and I'm like, oh my God, no wonder. It's like, it is tight. Those muscles are so tight. So no wonder you have painful intercourse, or, you know, your bladder, you feel like you have to pee every 5 seconds. Well, up here, these muscles are great, but down here, you've got nothing. So really getting into a pelvic floor therapist to have them do a good assessment and really help the patient engage those muscles and teach them exercises at home that they can do is really beneficial. And a lot of times, I encourage patients too to have their partner go with them. I know sometimes it can be embarrassing, but guess what? If you have a partner who can listen and say, okay, well, we need to engage this muscle. Okay, well, if a woman, there's tools that you can use, and PTs, pelvic floor therapists, are amazing with explaining that. But sometimes it's like, okay, well, I need somebody else to help me here. Okay, well, engage your partner, and then, you know, another good pelvic floor therapy exercise, sex. You engage those muscles, right? So if you're doing those exercises and you happen to, if one thing leads to another, guess what? You're engaging those muscles, so everything's good.
Everything. Listen, that is a
Listen.
good day when that.
Yes.
I mean, that is.
Yes.
But I took I have a Peloton. And they have like exercises that you can do that's just not on the bike. And they have this series, and it's a menopause series, and I love it. And they were doing pelvic floor exercises. And what we did was, like, you do a bridge, right? Like an inverted bridge, right? And you lift one leg up and just go up and down.
I've seen, yeah.
So I was doing that, and I was like, I've done this before, but nobody ever says it was pelvic
That's
floor.
what it was.
As I'm doing it, I'm like, am I really? But you are holding everything tight. Like your core, it is tight, and so going up and down so that you don't fall over. It was great. I was like, well, that's cool, and I never knew that helped the pelvic floor. So I think sometimes people don't know the exercises, and they think, oh, I can't do that. How am I going to engage? We've all done the bridge. Like, you went to any yoga class or Pilates, you've done the bridge.
And another interesting fact is your core. If you have a strong core, that helps your back. It helps your pelvic floor. It helps all of that. So having a strong core is really important as well. Yeah. One thing that you mentioned, so I had a patient, she had reached out to me, and she had been to numerous providers. Now, granted, remember, I'm virtual, so I can't get my hands on her.
Right.
I'm still virtual. I don't have my brick and mortar yet, but so she came to me with PGAD, which is persistent genital arousal disorder or dysfunction, discomfort. And it's basically,
I don't have any idea.
I don't know. Those were a lot of initials. Gisele threw a lot of
initials. I
did.
threw a lot of stuff out there. Sorry. So basically, it's having sexual arousal without being aroused, right? Or having spontaneous orgasms. It's a misfire.
I had no idea that could ever happen.
Oh, yeah. And for some patients are like, oh my God, sign me up. That's amazing.
Yeah.
But for those patients, they're like, no, it's absolutely horrible. Yeah. And some patients, truth be told, and it's very sad, have actually taken their life because nobody has been able to help them. And so that is truly a thing. It is a thing. And so anyway, she had reached out to me, and she said, you know, I want to know if you have any experience in treating PGAD, you know, and I told her up front in my email, I said, look, I'm virtual, but I take a very detailed history. I can talk through all of this with you. And so we were able to do that. And I said, first and foremost, and it was classic signs. So I was able to get her into a pelvic floor therapist. I was able to get imaging done that we needed to, just to make sure there wasn't anything going on with any of the nerves that can innervate. And so the pelvic floor therapist called me and she's like, oh my God, you like hit the nail on the head. And I said, but I'm not quite convinced that it's actually nerve. And she goes, no, which led her to our discussion. It was actually stemmed from her core, from her diaphragm. So it's pretty impressive, right? So there's all of these muscles work together, right? And everything is interconnected. I always make the joke, well, you know, the hip bone's connected to the knee bone, right? Like
I remember that.
And it all works together. So so pretty impressive for sure. Again, phone a friend, have a pelvic floor therapist on hand, or know of one that you can refer to for sure.
I have another question. Can't believe I'm asking this question.
Okay, wait, did you just say I can't believe I'm asking this question?
Yeah. So it's going to be a good question. We're all coming in. Yes.
How do you know, like, what's the best lubricant to use and what's safe and what isn't safe? Because isn't there like probably lots of ingredients that may not be good for you? Is there one that's healthier?
That would irritate it. That stuff would irritate
I mean,
if you had stuff.
Like if you're very sensitive, certain, you know, like, I mean, you can see all these different ones where it said this makes you hot, this makes you cold, this is the guys, this is the girls. I mean, probably lots of that kind of lubricant is probably not very safe, I would think, because they're probably putting stuff in it that you shouldn't even have on you. But how would you know what to start with if you were having painful intercourse?
That's a fair question. And so, and I love that you asked that, because there are a lot of products out there, right? And especially when we have somebody whose vestibule is already just angry or inflamed. We want to be careful with that, right? So we really want to be careful with that. We don't want anything that causes burning so there's a lot of scream creams that people are selling, right? That may have an ingredient that makes things hot. And so,
I couldn't even imagine. I'm like, what? Why would you want it hot?
Of course, for me, I'm like, well, have we done a good exam to see what's going on? But, so to answer your question, there's a lot of, you know, water-based, silicone, all of those lubricants that are out there. What I can tell you is some of my favorite ones that I like. My ultimate favorite is Uberlube. And it is an amazing lubricant. And I can't believe I'm gonna say this on video. I cannot recall if that's silicone based or not, but
my OB told me that was when I did ask that question, and he said it was Uberlube.
Uberlube is
his go-to. That was his go-to.
Uberlube by far is my favorite, and I can tell you it does not dry out. It's not tacky. The key to it is, so a lot of times we have women who are like, look, I am dry, it hurts to have sex, we have to use so much lubricant, what do we do, right? And so you know, they go to the store and they get the KY, or my favorite is the KY, non-tacky or non-drying. Okay, when you look at it, those products are made with such a high osmolality, right? And so if you're using that product in an environment that's already compromised, you have just sucked out whatever moisture, sucked out whatever lubricant, anything from this environment that it had. And so you're gonna have to reapply, and women are like, oh my God, it hurts, I'm drying, I'm getting UTIs because of the inflammation, I'm getting, you know. And so Uberlube is a good one, Silk is a good one.
I think I've heard of that one.
And Wicked. Those are I would say three that I would recommend. I always have stories, you know. I
love stories.
Okay, because I love the name Wicked. I mean that
all of them,
I'm like, I'm picking that one.
I kind of like
wicked good. It's wicked good. I'm gonna go get my lubricant from the car because it's wicked good.
Yeah, but can you get those? You have to order those online, I'm sure.
You can order them online, or you can go to this. This is where my story is going.
I get it, because you have to ask for permission to open up the cabinet. It's usually some young sales guy that has to open the cabinet at CVS or wherever.
Well, CVS I have not seen, and I like to peruse the aisles so I can tell my patients what they can get.
Yeah.
Right. It's not at CVS.
Okay.
Anyways, so
Better.
it's so much better. So this is when I was back home still in California, working at a very busy OBGYN practice, and I'm talking to this lady, and the subject comes up, and we're talking about sex and, a lot of other things. And I brought up this subject about lubrication. And she's sitting there prim and proper. She's older, like not one hair out of place. She's dressed to the nines. Like she's classy, right? She is just great. And so I'm talking to her, and I said, yes, there's this one lubricant called Uberlube. And she goes, oh, I've heard of it. And I said, oh, okay. I said, it's not, you can't really buy it at CVS. I haven't seen it. I think you can buy it online through CVS, but there are some stores that you can go to. And at the time, it was really funny. So there was this one, I have to just describe it. So in Fresno, where we lived, there was Highway 41, and it kind of like went down, right? And so
of course,
the street, yeah. So up were the streets, the mall, and then it used to be an old Hofbrau. It used to be an old brewery where they turned that into a store called Hustlers. And so,
oh my God, I knew it. I knew it was.
I knew. Yeah. I knew that.
Yeah. So I'm talking to her, and I said, I'm sure you can buy it. And in Fresno, we had a place called Susie's Bookstore.
Oh yeah, we have that. Yeah.
Yeah. And so I'm like, I'm sure you can go to, and she goes, she looked at me and she said, oh, Hustlers actually has it. It's in the back. It's like and I just went, good for you.
Good for
you.
You.
Know about it. You know it. And so I said, well, have you used it? She goes, no, I was thinking about that, but since you brought it up, I'm so glad. I'll make sure to go get some. And I'm like, hell yeah, you go get that Uberlube and you use it. I'm so proud of you. But it was just so, unexpected, because she was,
yes.
Anyways, don't judge a book by its cover. But I would definitely stay away from like the KYs and those things, because a lot of times they can cause further irritation. They can cause
drying, it's like chapstick. When you keep putting chapstick on too much, I know. I saw you put it on earlier.
I know.
But,
yes.
It's the same concept though, right?
Yeah.
Yeah.
Absolutely. Now, and some of my colleagues may roll their eyes at me and say, I can't believe that she just said this, but I'm going to say it. And I know, right?
We're like,
listen, I am going to say it. Coconut oil.
Oh, I've heard that.
Yes, and there are coconut oil based lubricants. Coconut oil, you can put it on your skin, you can use it for sex, you can cook with it, but that's also something that you can use for sure.
Yeah.
But yeah. So I would say the three that I mentioned are the top.
And then the coconut oil would be the backup if you don't want to go shopping and you have some in your kitchen.
Just make sure you like
take off the top layer.
Just keep it in the bathroom once you start using it.
Yeah.
Instead of
yes. But anyways.
Okay.
Yeah. See, that's awesome though. But that is something, because these are things that are lubricating and moisturizing, which is what is an issue down there. And I think the irritation and the drying causes so many different things. Well, now we have recap. We figured out the exercises. We know the lubrication, the estrogen, the testosterone also, the DHEA.
That's my biggest takeaway. That is my
Yeah,
biggest
it's my
takeaway.
favorite.
Is my biggest
because
takeaway
I
today.
know when I was trying to get, as we all know, trying to get the
Yeah.
testosterone here, they would give me a prescription for DHEA, and I'm like,
So that was oral DHEA.
Correct.
Oral
Correct.
DHEA. I have patients on. I don't have patients on it because I usually take them off of it. Oral DHEA, I have found in my practice, is not very beneficial. Now, DHEA vaginally is a completely different story, right? Oral DHEA is not beneficial. If you want to increase your hormones, then you replace it with estrogen, progesterone, or testosterone. Yeah.
right. It was kind of like how you were saying earlier, like with, people think, oh, that I'm taking hormones just for the symptoms.
Right.
You're not. That's not the concept. The concept is you are replacing what you are actively continuing to lose. Like that's and I think that when you realize that and get into that mindset, you realize, oh, okay, I'm taking the symptoms getting decreased and going away. That's the best part of it. But it's actually you're protecting yourself for cardiovascular, for bone health, and everything like that. So I think that sometimes people, well, I'm not having symptoms, I'm not having hot flashes, so I don't need to go on it. No, you do, because you're still actively. So I think that somewhere still is not. People get it, but they don't.
Right.
Do you know what I mean?
Oh, for sure, for sure. And that's why trying to educate patients as much as I can, or as much as we can, educate the population about what's out there. Is so important, and just giving them options and saying, hey, look, there's these resources that you can go and look at. You can look at the Menopause Society, go to the Urology Association, go to which I need to see, if I don't know if they've updated. Anyways, there's podcasts, there's other doctors out there that are talking about this stuff. Seek them out too. Get all the information and weigh it out and see what works best for you. But there are a lot of options out there for sure for patients. Now, we talked about lubricants and we talked about hormonal treatments for vaginal health. There's also some over-the-counter things for somebody who's like, listen, I just don't want any hormones. Okay, I respect that. I respect that. Hyaluronic acid suppositories are amazing. That can help build the collagen. It's not estrogen.
I've never heard of that.
Right.
DHEA. But there are some things out there that can be used as well, non-hormonal things, if we have patients who are completely adamant about no hormones. And I have a few of those, and that's okay. As long as we're upfront and honest with them and say, hey, look, we can use this as a moisturizer. It's a vaginal moisturizer to see if that helps. It may not, it may not give us everything, or it may not prevent or treat everything that we are hoping for, but if it's giving you some sort of relief, then that's okay. And there's actually there's one company that I know of that's reputable, that makes one, and then I have seen some over the counter in the pharmacies too, where you can use, but that's an option as well. For a moisturizer, there's a difference between a lubricant.
Okay, that was my next question. That was it. What is the difference?
My GYN, who she recommended this and said, Bonafide, I think.
I've heard of that.
Yep.
Yeah, Bonafide.com. That's the company.
But it's just a moisturizer, like,
right.
That's it.
Yeah. So it's not going to treat, Deb.
Right.
So it's going to it's like dry skin, right? So we put lotion or moisturizer.
But you have to keep doing it like all the time.
Exactly.
Yeah.
Exactly.
It's not
But,
treating.
I mean,
it's covering the symptom.
Right. Well, but then it can similarly be said with estrogen, right? Well, you got to use it all the time. Well, yeah, but you're going to get more out of it because it's the hormones that are occupying those receptor sites, right? So but definitely a difference. But again, if we know patients, or if we have patients who are completely adamant that don't want to use any hormone-based anything, that's an option for them as well.
Yeah. So what would you say, like, for women out there who are like, ooh, I think I have this, maybe not. What are the signs that you're like, okay, now this is to the point where you really do need to see a doc? Like, is it?
In regard to vaginal symptoms?
Yeah.
So if they're having recurrent UTIs, or they're having that urgency, that frequency, they're getting up in the middle of the night, right? I like to look at everything as a provider, right? Because my training is, okay, well, if they're getting up in the middle of the night, is there something else going on, like a blood sugar issue?
Yeah. Oh, right. Yeah.
Right? So, but if everything checks out and it's just, look, these symptoms line up with GSM, let's treat GSM. There's no harm or foul to sit there and say, let's try some vaginal estrogen cream, or hopefully Intrarosa if we can get it covered by insurance. Let's get these symptoms checked out first, right? But if they're coming in with recurrent inflammation or infections, what they think may be an infection, there's no harm or foul to try to get them started on something.
Perfect. I think that, just getting the conversation and also just having somebody that you can talk this with, because I think sometimes people think, oh, it is just, I sneeze, pee a little bit, or they don't realize what it can continue to go into without some type of treatment.
Yeah. And that's the take home, right? Like, and I've said this I say this all the time. I say this from the beginning. We need to listen, actively listen to what our patients are saying, and we need to believe them, because they've been in their bodies. I haven't. I'm like, give me the information. Yeah. I need to put my MacGyver hat on, to figure out what's going on with this patient, right? So we can't just assume that everything is just normal aging, right? It can be a little difficult being virtual, right? And I've had some providers really challenge me on that. But guess what? If you take a good history and you know what questions to ask, you're going to get your answers.
Exactly.
Yes, and that has not failed me yet. So, making sure to get evaluated. We really want to support that tissue. We want to support that tissue. We want to prevent urosepsis in women. We need to, if a patient just wants a moisturizer, okay, we can look into that. But we also have to educate and say, hey, look, we can also use hormones that like is not systemic, right? It doesn't get into the system. And we really need to phone that friend and get patients on board with pelvic therapy. It's becoming more and more now in the States, but for the longest time, women are having these pelvic organ prolapse, right? We're having uteri come out, and cervices and bladders and rectums, and it's like, why aren't we exercising these things? We need to figure out how to prevent that from happening.
And are they just all, like, not all physical therapists are pelvic health?
No, physical
like, you have to look them up.
Yeah, you specifically have to look for pelvic floor physical therapists. And I don't know if it's changing now, but historically, all physical therapists are physical therapists. They have taken it a step further and have gone and done their own training outside of PT school, because again, it's not not learned in PT school, just like menopause isn't in NP, PA, MD programs.
But people like yourself who have gone the extra step
and done it, right? Yep. And so they go and do their own training on pelvic floor therapy to really get these patients treated, which is amazing. Which is it's a specialty within itself, right? So really getting in and getting a good physical therapist that understands that pelvic floor. And again, and I'm just saying this, I'm going to say this, it's not just women who have issues with pelvic floor, it can be men too, right? And so having a pelvic floor therapist is imperative. I wanted to throw that in there because guys can have it too.
Did not know that.
Yeah.
I did not know that either.
Yeah.
Well, see, we just learned so much. I'm telling you, and it is, I had no idea about the testosterone receptors down there, the DHEA. I'm like psyched. I don't know if my
too.
providers will be when I go and tell them with my notes, like, hi, hey, I would like this, also this.
Yes. And so one thing that I do tell patients is Intra Rosa has and again, I have like no ties to them. I just love the product.
Yeah.
I've prescribed the product for so long. And when I've had women tell me they and their partners can feel a physical difference.
I'm so excited.
Yeah. But there's a manufacturer coupon, and you guys need to go out there and tell the pharmacist if your insurance doesn't cover it, print out the coupon and say you guys need to apply the manufacturer coupon for commercial insurance. Here it is. And then they'll go through the whole rigmarole. Oh, it's not covered. And then, this is one of the big. I had a patient who I prescribed it for, and I used the. I always put a little love note in my prescription, big, block, bold, capital letters. Please use manufacturer coupon for commercial insurance price reduction. And so my patient texts me and she's like, look, I can't, they're not utilizing the coupon. They're saying it's not covering. And I was like, what? And in my practice, my patients have my cell phone number, so they text me, and I'm like, are you sure? And she's like, listen, I'm here right now. And so I call the pharmacy.
Good for you.
Yep.
I call the pharmacy, and I'm like, hey, this is, Gisele Thissen, nurse practitioner. I put in a prescription for a patient, Intra Rosa. I put in there to use the manufacturer coupon. And she's like, it's not working. And I said, okay, well, I'm not there, so I can't tell you how to input it, but it's you should be able to use the manufacturer coupon. I had one of my pharmacists that I use. I love him. He's awesome. And I asked him one day, I said, why are these other pharmacies not doing it? And he goes, because they're lazy. And I was like, thank you.
Probably,
I don't want to say that. I don't want to say that into the public, but, or they don't know how to do it, or it takes too much time, right?
It tracks, Gisele. All of this tracks.
It does, yeah.
So I'm on the phone with her, and I said, ma'am, listen, I don't just use it. And she goes, well, the indication here, it says to place the patch on, and I'm like, what? I said, it's a suppository. And she goes, I'm looking at the prescription. I said, what does the prescription say? She goes, estradiol, 0. And I said, Intra Rosa is DHEA. It's a vaginal suppository. You're trying to apply that to a patch. And she goes, oh. I said, are you the pharmacist? And she said, yes. And I said,
God.
I said, I didn't know. I
didn't know what to say.
Like, and literally for me to have no words is really shocking. And I was like, ma'am, because I'm in Texas, right? So we got to be polite, ma'am.
Yeah.
Have our manners. I almost said, bless your heart, because what that means.
And see, we all know what that.
Yes.
Thank you.
So I'm sitting there and I'm like, So Intra Rosa is a vaginal suppository. It's progesterone. It's DHEA. You put it in nightly. Like, I'm going through all of this with her, and I'm telling her, and I'm like, my other patient's waiting. I'm like, oh my God, I can't believe I'm doing this right now. And so anyways, long story short, she didn't know what Intra-Rosa was. And so she was trying to apply a coupon.
Oh, just something that wasn't even.
Yeah.
I can't,
So sometimes you really need to like stand there, I'm not saying be rude, but I'm just saying, hey, listen, teachable moment.
Teachable. Do you think she felt it was a teachable moment?
I don't know.
Bet, you know what? Hopefully she did. Hopefully she did. I always look
Bless
for the
her
sunny.
heart if she
Bless
did.
her heart. She will from now on, though. She will know. So
Yeah.
thank
Yeah.
you for
Yeah.
being patient with her.
Yes.
Listen. It's
Well, that's
all
cool.
about,
I mean, I know Debbie and I know I am so excited because I do have these. I will make all of my notes, and we can always, with my insurance, you can just also go on online and like text them in the like in an app type of thing.
Yeah.
You can, and then they get back to you within 2 to 3 days or whatever. But I will be like, oh, can we please
Use the coupon.
and
Yeah.
do this, and we'll see how far I get in PA, and then when they say sure, I'll be like, oh good, now there's a manufacturer's coupon that you will also
yes.
apply.
And so I always invite patients to do that, right? Well, and it's the same thing. I have patients who they can't get vaginal estrogen cream. Their insurance is saying that they don't want to cover it. And for them, it's like $238 for a tube of cream. I'm like, go to Mark Cuban's Cost Plus, sign up, and get the tube for $13.
Yep.
But this stuff isn't there, unfortunately. But yeah.
Well, cool. Well, I'm glad that we always have the go-arounds, that if you know the go-arounds for the insurance.
Thank you
so
for that.
That way, if people do ask us questions, and I just think this was such a very good, informative, I mean, it's something that has to be talked about. It's starting to come out, but not really. But it is something that, I mean, think about it, girls. Like you said in the beginning, know what you look like down there. Debbie, get a mirror.
I know.
Get a mirror.
Get a mirror. And just so that you know.
I just have to share something funny. You'll like this one. So I'm at the OB, and he was like showing me how to put some ointment on, and I said to the girl, I thought he said, get a hammer. I go, what do you need a hammer for? And he goes, no, I meant get a mirror. So they wanted to show me how to use a mirror, and I'm like, I'm not putting a hammer. It was just funny. I don't know how I got hammer from mirror, but that's what I thought he said.
I'm like,
He's
what
trying to
is
teach me.
happening down there?
I know. I was like, ugh. No, but he was trying to tell me that it's very important for every woman to take the time to get a mirror and to actually know. I got to
totally
give him credit
agree.
for that. He was, even though he knows that that's not what I'm going to do, he says, I'm still going to tell you.
Well,
Yeah.
I think that we all need to do it so that way you can see differences, because you have no idea until you know at least what it looks like starting point, and then you can just keep track of it.
Agreed. Because
agree.
then when a patient comes in and they're like, look, I've had this recurrent infection and it's itchy and it hurts and I just keep on getting creams. Okay, well, what did it look like? What does it look like now? I don't know what it looks like. I just know I have these symptoms. Okay, for a provider, okay, is it BV? Is it yeast? Is it lichen sclerosis, which can cause changes to the vulva that may be a precursor to vulva cancer, right? Like we need to know these things so that way we can really educate patients and we can get some good information and try to come up with a diagnosis, right?
Well, that is our takeaway. I'm going to say, girls, grab your mirrors and
Ask questions.
ask questions. And don't, the pelvic floor is very important. Like, do not think that it's not. And we need to do more than Kegels. At the bridge, find a provider that is a physical therapist that specializes in, that's perfect. And we are just so thankful that we have our
Gisele.
favorite nurse practitioner who specializes in women's health, and it's just perfect. Please tell everybody where you can be found so that way they can find you virtually.
So wishhealth.net. So that is www.wishhealth.net. PEALTH.net. So that is one H in there. My web designer did that on purpose. I still don't understand why she only put one H in there, but that's it. Or you can always call my office, which is 713-338-9474.
Perfect. I thank you again. We enjoy these. I always feel like we get so much information to help other women out there who are struggling and just don't know what to say,
Absolutely.
but at least they can. And I actually know somebody that does have one of those carbuncle things that they never knew what it was. So I was so excited, and I was like, if we don't talk about it, I will ask. But we did. So I can be like, hey, listen to this episode.
Yeah, and those are the carbuncles, are very common, right?
Yeah.
And they happen. And it's like, if we can prevent those from happening and treat that and get that, I mean, it's just the whole GSM, pelvic floor. Yeah. It's women's health. We gotta take care of all that.
And that was, yes, I stand corrected. Jersey will come in with carbuncle, but it's carbuncle. So
Carbuncle. I think I did add a B in there when I was talking about it earlier. So
Lord knows with Jersey, yeah. So we say thank you so much with our Gisele. Thank you, Debbie. We'd like to, if you like to listen to more of this, you can follow us on Spotify, YouTube, Apple Podcast, and we say thank you to our affiliate sponsors who are Good Day Chocolate, Parlor Games, Pantry Products, Isogenics, and Small Picks Magnets. So thank you
everybody.
Yes. Thank you again. We loved it. And as we like to say, Debbie, what do we say?
See you next Tuesday.
Next Tuesday.